All right, so we are going to move into the advanced management section. So I'd like to, I know he's somewhere in here. Yes, he's walking up. So Dr. Adam Dahlia came all the way from Boston, Massachusetts to join us today. So thank you for the long commute that you probably had to come. So assistant professor in Department of Anesthesia and Critical Care, and has been giving talks for us for some of our virtual courses on imaging and ECMO, and has done a fantastic job to kind of teach us some nuances of that. So we've asked him to come up and continue on that crusade to teach us about imaging in the setting of ECMO. So welcome.
All right, good morning everyone, welcome to Boston. I'm going to try to make the case for the routine use of echocardiography in the peri-ECMO period, and I hope that at the end of this brief discussion that I've made that case well for you. I have no relevant disclosures to this presentation. The objectives will detail the role of what echocardiography can be for adult ECMO patients. Some of the concepts are universal for pediatric as well. We'll discuss utilizing echo for cannula insertion and positioning, and also a little bit about how do we monitor the patient during ECMO with echocardiography. So what is the role of echocardiography in ECMO? And I think some of these questions also arise at the beginning stages of cardiac surgery. What do we need echo for in cardiac surgery? Now we can't even imagine doing cardiac surgery without echo. And I hope that's probably going to be the same for ECMO. So we have our pre-ECMO assessment. We're able to identify, confirm the pathology and the need for ECMO, whether it's VA or VV. We can also help rule out some contraindications to ECMO using echo. And I think most importantly, assist in the cannulation. We'll have intra-op or intra-ECMO assessments done with echocardiography. We can help troubleshoot flows during ECMO. We can evaluate the readiness to wean from ECMO. And then we have some echocardiographic parameters that we can use for post-ECMO assessment of our patient. This brief discussion is going to focus on the pre-ECMO and the intra-ECMO period. So first importantly, what equipment are we using? So currently at Mass General, we use one of these pieces of equipment. It's either the Philips or the GE machine. Most of our machines are the big Philips machine down there at the bottom left-hand corner, and that's for transesophageal echo. We use this mainly in the operating room, either post-cardiotomy shock, but we do sometimes go to the ICU, to the emergency department, much smaller spaces, and we need a much smaller footprint than our larger machines, and so we use this GE machine here. It's like a little laptop. And then even smaller, because sometimes we go to even smaller spaces like the inpatient floor or a trauma bay in the emergency department, and we'll need to use some handheld technologies. And so these are some of the pieces of equipment that we have. We have the Lumify, which is a handheld transthoracic probe, as well as the Butterfly, which many of you are probably familiar with. And so this allows for both surface ultrasound as well as transthoracic echocardiography. These, I think, are going to be more and more useful as we see medical students carrying around the Butterfly or the Lumify. I think that this is going to be one of the new stethoscopes in the next 5 to 10 years if it hasn't already supplanted that. This piece of equipment is very interesting. It's called the Imacor. It's a disposable transesophageal echo probe, and this can actually stay in the patient for up to 72 hours. And I think in critical care medicine, this is going to be an important piece of equipment. If you have a patient on VA ECMO or VV ECMO for at least the first 3 days or 72 hours, you can place this probe, and this can allow you to monitor the heart function, make sure the cannulas haven't changed, make sure there's not any intracardiac thrombus, LV distension, any of those bad things. You can watch for 3 days straight with this probe. You don't have to keep inserting and removing the probe. Right now, it's a little bit cost prohibitive, but I think that once we bring the cost of something like this down, this might become standard for monitoring ECMO patients in the ICU. So we'll jump into some echo examples that are real-world examples that we've had here at Mass General Hospital on patients. This is one of the first things that we like to do before we cannulate somebody for ECMO is we want to make sure that there aren't any contraindications to ECMO. It's obviously a very expensive, labor-intensive treatment. We want to make sure we have the right patient selection for this. So this is a transesophageal echo image. It's the mid-esophageal aortic valve long axis view. And you can see here with the red arrow that we've noticed that there's an aortic dissection extending all the way down to the root. And so this is a patient that likely would not be a great candidate, at least at our institution, for peripheral VA ECMO. And so we wouldn't have been able to diagnose this without some echo guidance. We have a separate patient that we were actually called for emergently that was undergoing liver transplantation that they requested peripheral VA ECMO. When we dropped our echo probe, same view, mid-esophageal aortic valve long axis, we saw some sludge or spontaneous echo contrast in that aortic root there, which was very concerning to us. As we were attempting to help guide them with peripheral cannulation, we started viewing the aorta, and we can see here that there was a thrombus forming in the descending aorta, and this is very difficult to have any adequate level of flow on ECMO if you have a descending aorta thrombus. So again, something that we wouldn't have been able to find or see unless we had some sort of imaging or echo guidance. And you can see there with the red star that intralumen thrombus that was forming. And this was from a low flow state. And potentially if we had gotten there sooner, and potentially if we had gotten the patient on ECMO sooner, we could have avoided this. But again, this is one of the importance of having some echo skills. So what do we really want to know while we're cannulating? So we want to know if any of the pathology is impacting our access. So we can have surface ultrasound to help understand when we're accessing the vein or the artery at that location, if there's atheromatous disease, peripheral vascular disease. And then more importantly, pathology that can impact the venous cannula, either placement or function. So any intracardiac shunts, any masses or clots, Chiari network inside of the heart, as seen here. And about 5% of the general population has some Chiari network. And so that can be difficult when you're placing the venous cannula, if you're not having adequate flows. So these things are obviously tough to see unless you have some echo guidance. And there are a few other pathologies, pacemaker leads, ICD leads. And this was interesting. There was a case report published a few years ago on a persistent left superior vena cava, where the venous cannula actually entered the coronary sinus because of the dilation of the coronary sinus from the persistent left superior vena cava, rather than in the right atrium. And so that prevented proper oxygenation of the patient. Again, something that we wouldn't be able to see unless we had echo. So we have our first case here. It's a 54-year-old male who presented to the emergency department, had some chest pain, and then developed PEA arrest. And we can see here we used our surface transthoracic handheld point of care ultrasound. We have the structures in the heart labeled here. And it was biventricular failure or biventricular dysfunction. And with any ultrasound, you want to have multiple views. So we had our 4-chamber view there, and here we have our cross-sectional or short-axis view of the LV. We have LV and RV dysfunction there, and okay. So it was confirmed that the diagnosis was biventricular dysfunction, biventricular failure, and we knew that we needed to start cannulating this patient for VA ECMO during eCPR. We started placing our arterial cannula. We used the guide wire through the right femoral artery, and we tracked it up using our transesophageal echo. We were able to identify it using X-plane. So again, we're using ultrasound, and we're using 2 different views on ultrasound to always confirm and see and know exactly what we're seeing and know exactly what we're looking at. And so we can see here that we see the guide wire in the descending aorta, and so that we're fairly confident that we're in the right location. We see there, we use X-plane, and we see that there as well. We then move on to venous cannulation. We follow and track the guide wire up through the hepatic IVC, through the hepatic, past the hepatic vein to make sure that the guide wire is entering the heart and not sort of curling on itself or getting entrapped in the hepatic vein. We see there that the guide wire is freely and it's heading toward the right atrium. We then take a look on our mid-esophageal bicaval view here, again, transesophageal echo, and we can see that we have our guide wire traversing the right atrium and going into the superior vena cava, and so we're fairly confident that we're in the right location. I think the thing here to stress is that wherever your guide wire goes, that's where your dilator and cannula are going to go. So if your guide wire is curling up in your hepatic IVC, that's probably where your cannula is going. So it's really important to be able to identify the guide wire. And that's there with the red arrow. The other line was a central line that we were concurrently placing during this event. So we see here that we actually then placed the cannula, and the cannula went exactly where our guide wire went, and that's great. It went in the hepatic IVC, past the hepatic vein, and is in the proper location. We have the hepatic vein and IVC labeled there. So that was a cannulation that went perfectly well. So we would say, well, did we really need echo? Everything went well. We really didn't do anything. We didn't change anything. But it doesn't always happen that way, right? So we have venous cannula malpositioning. We could have inappropriate depth or outflow misdirection, for example, with the Avalon catheter. We can have abutting or going through the interatrial septum. We can traverse the tricuspid or into the right ventricle, can go into the hepatic vein. So there's a lot of places this venous cannula can go and the venous guide wire can go. And if we're not able to identify that on echo, we can't sort of alert our colleagues who are placing the cannulas that, hey, we may need to redirect the guide wire, pull it back, use a different guide wire. This was an example of a blind femoral cannulation. You can see here with the red arrow that the venous cannula decided to make a turn on its own inside of the patient. And this is a situation where we made a bad situation even worse. And this was done blindly. And so if you had echo during this cannulation, we would have been able to see that we don't see the guide wire in the right atrium. We don't see the guide wire in the superior vena cava. And so we may not have cannulated that patient using that route. And so this, again, we already have a critically ill patient that's requiring ECMO. We don't want to make things any worse. You can see here that we have a venous cannula that's actually traversing the interatrial septum, and that's one of the things that, again, we would not be able to diagnose without some sort of imaging. Stressing the importance of guide wire direction. We have an example here where the guide wire decided to make a turn through the tricuspid valve into the right ventricle, and if the guide wire was left there, that's where the cannula would go, and it potentially injure the tricuspid valve and even the right ventricle. Our patient that was arresting in the emergency department was then able to be decannulated from VA ECMO. Unfortunately, a short while later required VV ECMO cannulation, which is one of the most, for hypoxia, which is one of the most common indications for a second run of ECMO for us in our institution. We were later called because the patient was having some hemodynamic instability, and so we came with our surface ultrasound that we see here, and we were able to notice that there was a pericardial effusion, as you can see here with the red arrow. That's the right ventricle. The right ventricle was working well because at first there was thoughts, well, did we let the patient remain hypoxic long enough that now we have RV failure? But that wasn't the case. You can see here the RV is working quite well. We then placed our transesophageal echo probe, and we noticed that our pericardial effusion was getting larger. We also noticed a hyperechoic structure in the right ventricle, which was relatively concerning. So we went to our transgastric view. This is the transgastric mid-papillary short axis view of the left ventricle. And you can see here the red arrow. There was a hyperechoic structure here that was very concerning. It ended up being the cannula that was placed, and we had to take the patient to the operating room relatively emergently. And this is what we found here. You can see that the cannula actually perforated the right ventricle. And this was a scenario where we were placing it blindly. We had great access, we had great flow, and we had some hemodynamic instability, but weren't really sure what was going on. So the good news was that we had echo in place. We were able to identify that there was a problem. We were able to take the patient to the operating room relatively quickly, and we were able to repair this right ventricular injury here. And so this is obviously one of the worst case scenarios that can happen from ECMO, but I do think that it's important that having echocardiography guidance can help prevent these injuries, can help prevent these issues. And while we may not all be experts in echocardiography, some of the basic views that I showed you here today can really be attained with 2, 3, maybe even 4 different views. I think that having competency in at least some of these POCUS or point-of-care ultrasound techniques can really help save the patient, can help avoid injury, and can really help improve outcomes. So this is an area that I'm researching, and I think others in the world of cardiology and cardiac surgery are also researching. And I would imagine that outcomes will be better if you're guiding, inserting, and monitoring your patients with some sort of echocardiography. Thank you.
All right, up next we have Veli Antonini, who is a perfusionist, and I won't even attempt to say what hospital in Italy. I will massacre it, and I don't have as cool of an accent as she does when she does it. So, and I also think for any of you active in social media, if you are not following her, you are losing out big time. Foam ECMO, and I'm sure she'll have it up there at some point so that you know exactly which one it is. I would say her skill is synthesizing what somebody will say, and if you're watching the ELSO social media accounts now, she'll listen to something, and then 2 seconds later, there'll be a beautiful infographic and like synthesized information that I don't understand how she does it. So it's a privilege to have her share with us. She's going to do crisis management and kind of go through some of the ECMO emergencies, but prepare. The imagery she creates is, I am jealous of her. So please welcome Velia.
Sometimes we need help during ECMO support, help to understand how we could face critical emergencies and complications on ECMO. This is a topic I care a lot. I have no disclosure except for my co-authorship in the chapter 7 of the new edition of the Red Book, which is about circuit malfunctioning and crisis management. So, how to deal with emergencies on ECMO? This is an accidental decannulation. Probably the strategy to manage accidental decannulation is not trying to clean up the blood, at least at the beginning. There is something we need to do to try to save the life of the patient. But for accidental decannulation, as for other main ECMO emergencies, the best strategy to avoid the high risk of associated death and the high risk for bad neurological outcome is maybe try to prevent complication. Because if you are able to properly manage your ECMO cannula, to properly monitor the insertion site and to properly secure the tubing, maybe you're going to avoid this kind of complication. So you need to prevent complication. You need to define your policies, you need to define your procedures, and you need to prepare at best to manage this kind of patient. Because managing patients on ECMO could be completely different from managing patients who are not on extracorporeal life support. Think to cardiac arrest. The strategy to manage cardiac arrest while on ECMO could be completely different from managing cardiac arrest with conventional advanced life support. You need to consider the configuration of extracorporeal life support. You need to consider that we could have some reversible causes of cardiac arrest, which could be ECMO-related, for example, hypovolemia in the patient on anticoagulation, because maybe you have a massive bleeding ongoing. You could have a tension pneumothorax. You could have a cardiac tamponade as a consequence of cannulation. So you need to think to this kind of complication. Maybe you are on BA ECMO and you have an aortic root thrombosis with a non-ejecting left ventricle, and this is not occurring in the normal patient not on ECMO. Moreover, you need to think to potential circuit complication. We could induce cardiac arrest. So maybe your patient needs a conventional cardiopulmonary resuscitation, but you also need to think to the circuit and replace the circuit as an additional strategy for advanced life support. So you need to have protocol. You need to prepare your protocols, and you need to discuss these protocols and share these protocols with your ECMO team, because everyone caring for the ECMO patient needs to be aware of this potential diversity of ECMO patient compared to the conventional patient to be able to face emergencies. You also need to prepare to manage mechanical complication. This is an example of a flow chart to manage impaired ECMO blood flow, again from chapter 7 of the Red Book. And you should prepare this kind of protocols and converting protocols in flow chart, able to be kept at the bedside, maybe on your ECMO cart, so that everyone caring for the ECMO patient, or maybe everyone assisting people caring for the ECMO patient, is able to understand, to train on this kind of flow chart. And you should prepare this kind of tools for every potential life-threatening ECMO complications, starting from mechanical complications, so pump failure, membrane lung failure, circuit disruption, accidental decannulation, the presence of air within the circuit, and also you need to prepare something like that to manage common ECMO scenarios, which could be life-threatening potentially. So think about recirculation of VV ECMO, think about return obstruction or drainage insufficiency. If you do not have any drainage, you could not have extracorporeal life support. So you should prepare your team on all of these kind of potential problematics. Then you need to prepare your equipment. You should have also, always clamps available on your ECMO cart. You should have an end crank if your centrifugal pump could be manually operated. Otherwise, you need a backup drive to manage pump failure. And you need a lot of stuff. You are going to need an ECMO cart. This is a really well-organized ECMO cart. Moreover, it's an ECMO cart which is absolutely visually able to help to support people in emergencies. This is from Twitter. What should you keep in your ECMO cart? Everything which could be required to manage emergencies. So to manage an emergent circuit replacement or replacement of a circuit component, so tubing clamps, shifters, you need connectors and tubings. You need also what you need to manage a cannulation, an emergent cannulation, or maybe a replacement of a cannula or an addition of a cannula if you need to switch the configuration of extracorporeal life support. And again, you should keep always also tools which could support your bedside specialist as checklist to manage eventual complication, but also to be able to do conventional support for the ECMO patient. Then you need to prepare your bags because maybe you need to transport your ECMO patient both in the hospital or out the hospital. So you need everything which could be required to manage the ECMO patient outside of the ICU. You're going to need a lot of stuff, starting from medication, devices to manage airways, devices to provide mechanical ventilation, oxygen, and again, everything which could be required to manage all the ECMO complication. It's a lot of stuff, so again, maybe you should need a checklist. I use checklist quite for everything. This is my checklist that I use when I move the ECMO patient and when I arrive to the OR or when I go back to the ICU. I check everything in that list. It's really easy. These are really stupid things, but if you do these stupid things, maybe you are going to be able to prevent the interruption of gas supply. You are going to prevent pump failure, which is mostly due to lack of power as the battery becomes exhausted. You maybe are able to prevent an accidental decannulation because you have properly secured your ECMO cart and your tubing. So it seems a stupid tool, but it could be really useful at the bedside. If you keep something like this for ECMO monitoring, for circuit monitoring, and for simple intervention like that, you could really support your bedside specialist. Then you need a circuit. And coming to the circuit, you need to consider that modern circuits are usually pre-assembled. You just need to connect the priming bag to the circuit, and it's done. So these are really, really easy to be prepared and to be primed in a few minutes. Should we keep a circuit pre-assembled and primed in the ICU or in the OR? Or should we prepare the circuit just when you need the circuit, so at cannulation? I have no definitive answer to this question. I think that having a circuit ready to manage emergent ECMO implementation or to manage emergent circuit replacement could be a good idea, could be advisable. And it was advised in the chapter 7 of the REC book. We have some literature supporting these possibilities, so supporting the safety from a microbiological point of view and supporting the safety from a technical point of view, so on the ability oxygenator to be able to provide gas exchange always also after a long period of pre-priming. If you decide to prepare the circuit in advance and to prime the circuit in advance because you think that it's easier for your perfusionist or for your ECMO specialist to prepare a circuit when they are quiet, in a quiet room, with no pressure, with no rush, with the possibility to take all the time they need to follow the checklist, to do every kind of connector, of connection they need, to add eventually sampling lines and so on. And you should consider that you should follow some rules to improve the safety of your circuit. So go for a complete crystalloid priming, a clear solution, without adding any glucose, without adding albumin, without adding blood, so without adding anything which could promote the bacterial growth and keep it sterile. Personally, even if it is not required, I wear sterile gloves and sterile gown, and I made all the connection before taking the circuit out of the box. So I add my sampling lines, I add the eventual connector I need before removing the circuit. How long should we keep this pre-primed circuit? Again, I have not the definite answer. It is advised in the most recent ELSO guideline for the ECMO circuit that you could keep this circuit for at least 30 days and is stable. We, again, have some literature saying that it could be safe up to 60 days or maybe more. It's up to you choosing if keeping a circuit pre-primed, if choosing a circuit pre-assembled but not pre-primed. You should define your protocol to keep your team safer and to keep your patient safer. We ran a small Twitter poll in the past week, and as you could see, most of the responders, which were about 200, say that they build the circuit in advance and they keep the circuit pre-primed for up to 30 days. The other thing you need to consider about your circuit is if you want a basic ECMO circuit or you want to add something to your circuit. So if you want to add sampling lines, if you want to add monitoring devices, if you want to add any access on the drainage tubing or on the pre and post membrane lung ports. Again, it could be dangerous. Every kind of modification, every kind of adaptation of a basic ECMO circuit could increase the risk of complication. Every connector is a potential source for thrombosis, is a potential source for blood activation. Every connector could be the determinant of a circuit disruption and a determinant of the entrance of air within the circuit. So you need to consider carefully the pro and con of adding anything to your basic circuit. This is the same machine, two different circuits. These circuits are really complex. I would never advise someone to use this circuit in the ICU, but it's what I need in the OR. So maybe I need sampling lines, a lot of sampling lines. I need the access on the negative pressure side to administer quickly load and fluids, and maybe I need access on the drainage line to provide cytokine removal, which is pumpless. But maybe it's not what you need in your patient on ECMO in the ICU. A basic circuit, again, same machine, different circuit, could be easier to be managed by your staff, could be easier to be prepared. So you need to consider what you need for that particular patient and adapt your protocol, the protocol you have defined in your center, to that particular patient. What I always add also to a basic ECMO circuit are a couple of sampling lines before the oxygenator and after the oxygenator, which I also use to check the pressure if I have any doubt about the reading of the pressure integrated in the circuit. And I also use these sampling lines to eventually provide a renal replacement therapy if there is no option to provide renal replacement therapy on the patient. Again, we have run another Twitter poll, and most of the responders, in this case were 100, say that they prefer a circuit which could be as short and as simple as feasible. Again, check on a case-by-case basis. So now we have our procedures, our policies, our protocols. We have our equipment and our circuit. It's enough? No. We have learned during pandemic that a ICU is not an ICU bed, is not a mechanical ventilator. The ICU is the ICU people. And the same is true for ECMO. If you want to open an ECMO center, if you want to build an ECMO program, if you want to expand your ECMO capacity, you need ECMO providers. Otherwise, you could buy the most advanced ECMO circuit, the most advanced device, but these are just pieces of plastic and pieces of metal. Your perfect procedures, your perfect protocols are just pieces of paper. You need an ECMO team, a multidisciplinary ECMO team taking care not only for the circuit, but also taking care for the patient and for his family. So we need a competent multidisciplinary team of ECMO providers, and if you want this kind of team, you need to cover for their educational and training and retraining needs. You need to expose your team to a comprehensive theoretical course. This is the ELSO Foundation. You need to expose your ECMO people to water drills to learn the basic, but you also need to expose your people to advanced simulation training because, as you learned in the previous talk, it is really much more effective in improving the competence of your team. This is the adaptation of the Miller pyramid to ECMO. You need to move your people from 0 to a level of knowing, and then you need to make your people able to manage complication at the bedside. It takes time, it takes a lot of commitment, but it's what you need to do to keep your patient safe. This is what you need. If you want to do ECMO, if you want to do ECMO at the bedside, you need to be able, at least, to cover for all of these topics, which are basic, and covering also the emergency procedures. Again, all the emergency procedures which could keep the patient safe. So you need to be able to manage all the potential emergencies. You need to be able to come off ECMO emergently, and you need to be able eventually to replace the circuit in emergencies. You could find all of this in chapter 54 of the ELSO Red Book. I have a little bias, but it's okay. You should be creative about ECMO education. During pandemic, in my center, as probably in most of your centers, we had an increased number of ECMO patients, an increased number of newly introduced ECMO nurses and ECMO physicians, and a limited capacity to offer education and training, which is not a good combination. So I've tried to do something different with what I have at the bedside. I have created a sort of video modules, video scenarios, to try to train my ECMO nurses, my new ECMO nurses. Is something really basic. It's not intended to replace a comprehensive course or a simulation course, but it's something they have in the ICU. There is a folder in the common desktop of the ICU. You could have access to this folder when you like, when you have time, during your shift, anytime you like, and all the times you like. And you could open one of these videos and understand how to manage this complication, but particularly how to prevent this complication and how to detect this complication at the bedside so that you could be able to provide a solution. I've tried to translate one for you. This is return obstruction. In the original video, you have the audio with a person telling you everything. This is the monitor of the system we mostly use in the ICU. They are going to see what is going to happen on the ECMO circuit with explanation, obviously. But they are also going to be understand what could happen on the patient. If you have a return obstruction, you need to check the returning line of your circuit because maybe it is something really easy, like a clamp. or like a compression. It's really basic, but most of the time you have simple solution for your problem. Maybe it's just a kinking of the line, or maybe it's not. So you also need to check your cannula, and you need to check the patient, because maybe the problem is not in the circuit, but is in the patient. So it's something really, really easy, but I try to find a solution for the lack of possibility to train my team. And they also need to understand that sometimes what they think is the problem is it's not, because maybe it is not a return obstruction, but it's something else. So this was my strategy. And to summarize, in my opinion, the best response to ECMO emergency is prevention and preparation. Define your own policies and procedures, prepare protocols and checklists for everything, prepare your circuit and your equipment, but particularly prepare your team. How? With practice, with simulation practice, if you do not have enough ECMO cases. The less the number of your ECMO patients, the more you need to train and retrain as a team, because you are going to face the emergency with your team. And then you need to prevent again. How? Minimize circuit manipulation before the run and during the run, minimize procedures, invasive procedures on ECMO as feasible, minimize transportation as feasible, monitor both the patient and the circuit continuously, and then, if complication occurs, manage the complication as a team, as you learn during your simulation practice. Do not miss the new edition of the Red Book. Do not miss our upcoming courses. And this is my Twitter handle if you have any comment.
Beautiful. Absolutely beautiful. And I don't think people appreciate, she creates all those graphics. That's not just clip art. Those are things she's created. So impressive work. So I'm sorry that you have to follow that. I hope you're ready.
I'm sorry too.
So I'd like to invite back up Phil Mason, who is out of San Antonio. He's in retirement mode, so retired colonel from the military, and apparently has to go back to work because his wife's sick of him being home. So he'll stay in San Antonio at University Hospital. You poke just as much fun at me, so this is really enjoyable that I can do this.
Way more.
So he's going to talk about his love for benzos and all sedatives, and talk about the awake and extubated ECMO patient.
Thanks. I think I'll just start with these words. Game on, Liz. Game on. Hey, I'm Phil Mason. I met you all yesterday briefly, and now I'm back to deliver a talk. As Liz said, I just retired from the military, which means my disclosures just got a whole lot shorter. I have none. I have actually a ton of financial conflicts, but it's mostly me owing money to people, not people influencing what I'm going to do. So the talk I was asked to give is about the awake extubated patient. And I kind of modified it to say the awake extubated VV ECMO patient to start with. In veno-arterial ECMO, it's crystal clear to me. They should all be awake, almost all be awake and extubated if they don't have lung disease. It's much easier to do. We don't ask the question, should we be extubating our balloon pump patients, or should we be extubating our Impella patients? And so we shouldn't be asking that about VA ECMO either. I think the answer is apparent. And then there's another piece I added to it also, which is about ambulation. It's nice to be awake, it's nice to be extubated, but what we're really going for, or one of the key things we're going for, is mobility and rehabilitation and maintenance of strength. So I changed the title a little bit, Liz. Hopefully you don't mind. This slide, which you actually, Veli, it's a great slide. You can see this one says question everything, and then at the bottom it says why. And the slide is here to acknowledge before we start that there's some uncertainty in this, and I wanted to indulge your inner skeptics and my own inner skeptic. Awake ambulatory ECMO has a really awesome wow factor, really great cool factor. We all want to be doing it. The truth is the evidence for it is really kind of sparse. It makes sense to most of us. I think most of us agree that it should be done. There's a little bit of evidence out there. It's good to not be delirious. Delirium is associated with mortality and increased costs, et cetera. Mobility in the ICU is associated with shorter length of stay, less cost, et cetera. As far as extubating, wow, there's a lot of intuitive reasons to believe that coming off mechanical ventilation is good, but we haven't proven that it's good to extubate ECMO patients. It just seems to make sense. I'm not going to go into detail on that because I've only been allotted an hour and 23 minutes to speak to you. So let's just pretend that a really wise guy said this and we took it at face value. Wake the patients you must and walk them. And so I want to work now through a little bit of how we can accomplish that and how do you get from point A to point B. It's a little more difficult than it seems. Oh, good, the videos are working. I'm so grateful for that. So this is it, right? This is what we're going for. I know a lot of you have cool pictures and videos, show and tell from your programs as well. This is not that unique. This is some of my prized patients from recent times. I don't show you the patients that never walked, none of us do. But this is ECMO 2.0, right? This is what we're all going for. Look at these patients, they're up walking around. That guy on the right, we have a Burger King in our hospital in the basement. We took him to Burger King, and he really freaked out the staff when he stood up from his wheelchair and ordered his own hamburger and then proceeded to go outside and eat the hamburger. So this is ECMO 2.0. Now, look closely and you still won't be able to see this. What you don't know is all those patients have at least one femoral ECMO cannula. So that's my first point today, is ambulation with femoral ECMO cannulas is safe. There's just a few of the articles that demonstrate that. They're all case series. Some of them go back as far as 2014, 8 years ago, people. This is old news. Some of these describe arterial cannulas. There's a little more hesitance with that, but that's also safe. Clearly, venous femoral ECMO cannulas are safe for ambulation. So if that is holding you up, let today be the last day that you use that as a reason to not get out of bed and walk, okay? Now, what I'm gonna show next may be a little bit disturbing to some people, but I really wanna hammer this point home. It may be quite boring to some of the rest of you if your program is really aggressive with mobility, but we use a recumbent bicycle in some of our patients when they're not quite strong enough to stand yet. And here you see the ECMO pump in the foreground. You see some two femoral venous ECMO cannulas, and this guy's riding the recumbent bike. Any questions? Okay, so if you're waiting for the Avalon or Crescent to be placed to get the patient out of bed, please stop. Please stop. If you choose to use bicaval cannulas, that's your preference, that's fine. But it's not. It should not be a showstopper. All right. So let's keep working on just a few pointers on how we're going to get from our patient that's in bed to get our patient out of bed. And I'm going to use this thing called the pathway to failure to demonstrate that. So join me on this pathway to failure. It's a weird thing, a weird journey to ask people to accompany you on, but I think it will be instructive. And I think as I go through this, a lot of you, I'm going to see a lot of nods, like, yep, that sounds like my program. Delirium is very prevalent in our ECMO patients, very prevalent. Maybe 100% early on. A lot of it is hypoactive delirium, the kind that you don't know exists unless you screen for it, or whatever subtype they have, it's masked by deep sedation. But at some point, we want to wake the patient up, and that's where the trouble begins. So we lighten the sedation, or hopefully we just turn it off completely, but somehow we decrease the sedation. And shortly thereafter, the patient becomes agitated. They're thrashing, they're turning their head. They're dysynchronous with the ventilator, maybe they're pulling at devices. You all know exactly the patient I'm describing, right? So I'm seeing the head nods out there, it's coming, guys. Pretty soon the patient ends up in restraints. Oh my God, what a mess. At some point in this process, the patient is going to become hypoxemic, either because the circuit's chattering as the patient's coughing and bucking and the flows are cutting out, and or because their cardiac output's high. Sound familiar? A lot of head nods out there. Patient gets hypoxemic. And so if you're a bedside nurse or provider, oh my gosh, you just got really busy. If you're a provider, a physician, your phone's ringing off the hook. Everybody's in a tizzy. And at some point, what happens? The patient gets resedated. They get resedated. And congratulations, that is a fabulous short-term solution. Your shift will now end with no adverse events, and it's a great short-term fix for the problem. Unfortunately, the sedation that you use pours gas on the flames of delirium and perpetuates this cycle. So we should be looking for different ways we can interrupt the cycle along the way. So let's talk about that. All right, this is a commercial from the 1980s that aired in the US. You all may recognize it. This is your brain. This is your brain, it's an egg. This is Versed. Versed is midazolam for those that don't practice in the US. Versed is midazolam. This is Versed. This is your brain on Versed, okay? Are there any questions? Any questions? So that was the commercial from the 1980s. There's another slogan about drug abuse in the US that circulated in the 1980s, and it was this: just say no. Just say no. Nancy Reagan said it, so just say no. The use of benzodiazepines is powerfully associated and probably causative with the transition to delirium. Now, this is for lorazepam, the evil cousin of midazolam. But you see on the x-axis, the increasing dose of lorazepam. The y-axis is the probability of developing delirium. It looks like pretty much 100% to me, about halfway across there. Pretty remarkable. Has anybody had surgery out there? Raise your hand. What kind of surgery do you have, ma'am? No, I'm just joking. It's not my business. Totally not my business. I'm joking. I'm sorry. I get nosy sometimes. All right. When you all, whoever had surgery, when you were in pre-op, your anesthesia provider came out to the pre-op area and they started an IV and they gave you a medication. And after that point, you don't remember anything. You don't remember rolling back into the operating theater. You don't remember being moved over onto the OR table. You just remember waking up in the post-anesthesia unit a little while later. What they gave you was probably midazolam. So maybe that'll make the point a little more for you. So the patient wakes up, you're like, it's okay, sir, it's fine. It's Thursday, and you're in the hospital, you had pneumonia, and you're on a heart-lung machine. Mind eraser. A guy wakes up a few hours later, doesn't know where he's at. So please stay away from the benzos. Every month or two, probably every 2 months now, I come into work, and the fellow stops me at the door with a little bit of a panicked look, and they say, Dr. Mason, I've already taken care of this, but last night we had a resident on, and she didn't know. And one of the patients got a little bit agitated, and she wrote for Ativan. But don't worry, I already took care of it, right? So I don't use benzos in my practice at all unless you're having a seizure or you're an outpatient with anxiety. Maybe that's not for everyone. Maybe I've gone too far. But if you're struggling to get your patients awake, then I would encourage you to at least try and see if that's helpful to you. Okay, let's talk about how we provide ECMO, some technical aspects of how we can provide this therapy that will facilitate getting the patients extubated. I don't get any money from ED ECMO, but I took this really awesome video from their website, and Zach Shiner asked that I just give them credit for where it came from. And first of all, please excuse the ungloved hand. It's not mine. It is not mine. My fingernails are not really that nice. This is an animal model, okay, and it's the anatomy here is a little bit different than a human being, but you see an exposed portion of the vena cava that is very, very collapsible, and there's an ECMO cannula inside of it, okay? If you could see this circuit externally right now that's attached to this animal, it would be chattering or chugging or kicking or whatever you say in your particular center. And what you see happening there is that the cannula applying suction on the inside of that vessel is collapsing it. It's collapsing the walls of the cannula onto the vessel, onto the cannula. You see that right there? You can see the cannula being sucked and pulled, the vessel into the side holes of the cannula. This is really a problem. Okay, so this is what the lower abdominal portion of the vena cava in a human is like. It is very collapsible. Any surgeons in the room, you can put like one finger worth of pressure on that and collapse it very easily. If you are placing your venous drainage cannulas low in the abdomen, like this one, there's the tip of it. You can see it sits low. It's well below the liver edge. Then you are applying suction to the portion of the vena cava that's very collapsible. This is going to work great as long as the patient is deeply sedated and paralyzed. When you wake the patient up, the first time they cough, breathe deep, move, do anything, you're going to be on the pathway to failure, and you're going to start cycling down it. So it matters how we place the cannula. It should be placed deeper, where the tip of the cannula is at or near the right atrium. And that's good because it can drain from the right atrium. But also when the cannula sits too low, these side holes, they're in that low collapsible portion, and that's a problem. But look at the lower side holes, which, by the way, are the ones that get most of the flow. It's a separate talk. Most of the flows come through the lower ones. They're sitting in the iliac vein. How well is that going to work out for you? Okay, so the way that you place your venous cannulas, your drainage cannulas, really matters, and you can have a circuit that's much more resistant to chatter with an awake patient if you do that, if you place them a little more deeply. Actually, Adam Dahlia gave a great talk about imaging. Guys, there's no excuse to put the cannula in, secure it, put the dressings on, take the drapes down, go pat yourself on the back, get a chest x-ray, and then see this after it's all done. Use some sort of real-time imaging and figure this out as you go so you can get this placement correct. All right, that is not lungs with ears, though it kind of looks like it. So what I'm depicting for you here is lungs that are not working. That's why there's an X over them, or a symbol, in the right and left sides of the heart there. And I've also shown an ECMO machine. And let's talk just a little bit about ECMO physiology. This is going to bring in some of what Dr. Bartlett talked about yesterday to arm you with some physiologic knowledge to help you get your patients awake and ambulatory. All right, so the cardiac output, it goes out to the periphery, it comes back to the ECMO circuit and goes across the lungs. This is a great situation because the cardiac output is 5 liters per minute, which means the total venous return is 5 liters per minute, and all that goes to the ECMO circuit. What do you think the ECMO flow is going to be in this example? I went to public school in Texas, and I like easy math. 5 liters per minute. Wow. Okay. This is really nice because 100% of the venous return goes through the ECMO circuit. It's 100% oxygenated before it ever goes to the lungs, so it doesn't matter if the lungs are working. In that ECMO circuit, we can do the calculation. The O2 transfer, let's say, is 250 milliliters per minute. What did Dr. Bartlett say the oxygen consumption of an average-sized human being at rest was yesterday? I think he said 240. It's about 3 cc's per kilo per minute. This ECMO circuit in this situation is providing 100% of the oxygen that this patient needs. This is a great situation. We're fully supported. Let's take the same ECMO circuit, same patient, everything, and let's increase the cardiac output to 10 liters per minute. 10 liters per minute, right? Cardiac output went up. Now the total venous return is 10 liters per minute. Of course, we like to increase ECMO flow, but we can't always. So let's say the ECMO circuit flow is still 5 liters per minute. What's happening to the other 5 liters per minute of blood? Skips the ECMO circuit, never goes through it in the first place. Okay, so there's a venous admixture in the right side of the heart, and we end up with some blood that's mildly or even severely hypoxemic as it comes through. Remind me what the oxygen transfer was in the ECMO circuit in the previous example? 250. What do you think it is right now? It's still 250. It's still probably adequate for that patient. So what I'm trying to point out here is that just because the O2 saturation is low, it may be through this phenomenon, and you may not need to react to it at all. I think it's important that you remember that. Now, if the reason the cardiac output went up is because the patient started exercising, 250 milliliters per minute may not be enough. Okay, I acknowledge that. And so we need a plan on how to address that particular problem. What the plan should not include is terminating physical therapy. It should not include increasing the ventilator settings. It should go back, this is a very similar graph to what Dr. B showed yesterday. You should go back to the hemoglobin or the oxygen content of arterial blood, the CaO2, and find your solution there. So there's 3 curves here showing hemoglobins of 7, 10, and 15. On the x-axis is the PaO2, or it could be O2 saturation. And then the oxygen content of blood, or the CaO2, is on the y-axis. And you see, with a hemoglobin of 7 and a PO2 of 40, that's low, right? Saturations are like in the 70s or something. We have 7 milliliters per deciliter of oxygen in that blood. Not all of your patients will be fine with this, but a lot of your patients will be. Remember, Dr. Bartlett said the normal oxygen delivery is 5 times oxygen consumption. And we get into trouble when it's less than 2 times oxygen consumption. So just like everything else in your system, your body, it's redundant. There's a buffer, a safety factor built in. So these patients that are at 3-to-1 or 4-to-1 probably do okay. And a lot of these patients will be fine with the hemoglobin of 7. If they're not, again, the solution is not sedation, and it's not increasing ventilator settings. It's increasing the hemoglobin. Okay, if you take the hemoglobin up to 15 in this patient, exact same ECMO circuit, exact same lungs, exact same ECMO flow, the oxygen content of blood is now more than double what it was with a hemoglobin of 7. I'm not telling you to transfuse, Dr. Bartlett here? Okay. I'm not telling you to transfuse all your patients to 15. I don't do that. Most of my patients have a hemoglobin of 7 to 8. But if I'm running into problems with hypoxemia that I think is limiting physical therapy or causing other problems, my solution is increasing hemoglobin. That number is usually like 10 or 12, less, not necessarily 15. But that's a more physiologic-based approach to dealing with that problem. Okay, as I wind up here, I want to talk briefly, partly I want to show these pictures because I want to brag on the team I work with and just show you how awesome they are. I don't think many of them are here. I wish they were because they're amazing. But I want to talk about human interaction and what that means and how we can deal with anxiety and delirium using this tactic that, by the way, has no side effects, doesn't cost anything, doesn't have any drug interactions, but it's just not sexy, so we don't talk about it much. On the left there is one of my techs braiding a patient's hair. As a means of helping her work through some anxiety and delirium issues. In the middle there, this may seem awkward to some of you, but this guy had a lot of anxiety and asked the nurse to hold his hand. Man, again, no side effects. Wow, free, no drug interactions, awesome. The picture on the right is not great, but that's one of my really awesome techs giving a patient a temple massage to work through anxiety. I know you all want to come be on ECMO in my hospital right now, right? Somebody will hold your hand, will braid your hair, massage your temples. But please understand, and this is especially for the nurses in the room, because you all make medicine go round, you're the ones that make all this work. What you do matters, and there's sometimes non-pharmacologic interventions that can have a great deal of success. Finally, dogs are good too. We try to tie the patients back to their life outside the hospital in a lot of ways. The dog on the left there, you can see it's pretty small, may or may not have been smuggled into the ICU in an oversized handbag. Can neither confirm nor deny that. On the right there, this is something we really love to do. We can't bring patients' pets in the hospital other than that one that we snuck in. So we have the families bring the family dog or family pet to the hospital and just wait outside. And then we take the patient outside to see their dog. And these little things really add up and can help a patient deal with these issues. And more importantly, what it does is it keeps the patient in the fight. Because if the patient gives up or quits, then there's nothing you're going to do that pulls them out of it. And these are all ways we can tie them back to that. That's my talk on the awake extubated ECMO patient. Thank you, and I think there's time for questions at the end if you have any. Thanks.
All right, so rounding out the end of our first session, we will be moving over to Craig Rackley, who's an associate professor of critical care at Duke University. Never heard of the place. So he's also a member of our quality committee. He's going to be talking about weaning from ECMO, and I think at every single ECMO training course, we just get pounded with this concept of how the heck do you wean these patients. So hopefully he'll give some insights into what his philosophies on that approach is. So please, welcome.
Thank you. See if I can manage this this clicker here. So Phil, thanks for a great talk. I want to echo a couple of things Phil said. I think benzos are awful. I've gone almost as far to where if I come in and they've gotten Seroquel, Trazodone, and melatonin, I'm blowing my gasket. So I think less drugs is probably better. And I'm the only thing standing between you and liberation from this ECMO session. So hopefully you'll take something away from this and learn. So my goal, I think that what it says in there is all you need to know about weaning from ECMO. There's no way I can cover all the details of what you would need to know to wean someone from ECMO. And I think that's fine because there's no perfect mechanism to wean someone off of ECMO. There's no perfect measure that you use to show you how. There's no perfect way. I hope that I can convince you that there is an extremely good framework for developing a weaning or a weaning program. And I'm also going to tell you why I say liberation instead of weaning. A couple of disclosures before we go on, nothing that's really relevant to this conversation. So weaning, what does weaning mean? So it is to accustom someone or something to managing without something they've become dependent upon. You think of weaning sedation, weaning a ventilator, weaning a newborn, weaning a foal, weaning a calf, whatever, slowly reducing that level of support that they have become dependent upon because you feel they are not ready to be just set free from that. They need to slowly be separated from that thing they have become dependent on. Whereas liberation is more the act of setting someone free. Eliminating whatever that was that they were dependent on, whatever that form of life support may have been, whatever that drug may have been that they had gotten. And in critical care medicine and ECMO, our goal is generally going to be to liberate our patients from the life support that we have them on. Our goal is not for them to be on this forever. Our goal is to get them off of this, to liberate them from this in the quickest, safest manner that we can. And so, for whatever reason, Phil and I are nostalgic folks and like to back up and give a little bit of history. So in the 1980s and the 1990s, I would call that the era of ventilator weaning. If you were on a ventilator back then, you were slowly weaned. You were critically ill, you'd been sedated, you'd been on a ventilator for 7 to 10 days. It looked like you were getting better. Now we need to start the weaning process. That weaning process usually took one of two pathways. One was something called SIMV. How many of you have never heard of SIMV? I see a couple of hands. That's a good sign. In 10 years, hopefully I'll ask that question and everyone will raise their hand except for maybe people with more gray hair than me. So SIMV is a mode of ventilation, which in concept sounds great. You take a person who's on full support on a ventilator, and each breath is fully supported. They look like they're getting better, and you start to allow them to have partially supported breaths. So they're getting, say, 10 fully supported breaths, 10 partially supported breaths. And you wean them to 8 fully supported breaths, 6 fully supported breaths, 4 fully supported breaths, to the point where they're on all just sort of partially supported breaths. So that's method one. Method two was pressure support weaning. You take someone who's on a high level of pressure support and they're getting better, and you gradually wean that support down so they're doing more and more of the work on each individual breath. In concept, that sounds nice. In reality, that takes days sometimes. You're taking 2, 3, 4 days to go through that weaning process. And then comes something, the concept of spontaneous breathing trials. You take someone, they look like they're getting better, they look like they meet some sort of objective criteria that they're getting better. You turn their vent down to minimal settings and you see how they can do. If they can do okay, you potentially take them off the ventilator. So you assess that. The Spanish assessed this in the mid-90s and said, wow, you know, this is much, much better. They get off the vent sooner, they're out of the ICU sooner. Overall, they do much, much better. And now we've shifted more towards the idea of ventilator liberation. If you read a review on liberation from mechanical ventilation, it will say that today, whereas 20 years ago it would have said weaning from mechanical ventilation. Building on this concept, if we go to the 90s and the 2000s, sedation. So if you were on a ventilator, you were comatose. Comatose, comatose, comatose. What Phil showed you, the dose of benzos that made you delirious, you were on 4 or 5 times that, plus a bunch of opiates. The concern was that you were going to be horribly uncomfortable. You were going to have all this stress, trauma, anxiety, panic that's going to give you all kinds of long-term consequences. You're going to wake up, you're going to be thrashing around, you're going to pull out your tubes, you're going to pull out your lines. It's going to be a disaster. You're not safe if you're not comatose. And then building on the other concept came the idea of a spontaneous awakening trial. So instead of just slowly weaning that sedation over time, you turn it off every day. Oh my gosh, the panic that ensued upon this concept of just shutting off sedation. They're going to pull out their tubes, they're going to pull out their lines, they're going to wake up on a ventilator, they're going to be panicked, it's just going to be the worst thing in the world. And turns out, actually they do a lot better. They get off the vent sooner, they're out of the ICU sooner, they maybe even are less likely to die. And now we're more in an era of sedation interruption, which brought about, well, if both of these things work separately, let's just do them together. Let's wake up and breathe. Each day, turn off the sedation, see if they're ready to come off the ventilator, and extubate them when they are. And you accomplish all of these things. You get them off the vent sooner, out of the ICU, and I think most importantly in sort of making this case is they have less PTSD and delirium. It's not like they now have massively more PTSD and delirium, which gets a lot at what Phil was saying and arguing for that. So this is about ECMO weaning. So why the heck am I spending all this time on ventilators and sedation? Because I think the framework you use in liberating someone from ECMO is identical to the framework that you use in a spontaneous breathing trial or a spontaneous awakening trial. And I'll walk you back through our experience in VV ECMO liberation weaning. Before, we had no good framework. Someone goes on VV ECMO for respiratory failure. Each day we stand around and we talk about it, and you've got a surgeon, a perfusionist, a pulmonologist, a respiratory therapist, a nurse, and everyone hems and haws, and we look at a gas and we look at an x-ray and we look at the patient, and they're either too sedated or their x-ray doesn't look good enough, or we're worried about the gas, or the day ends in Y, or some other reason we can't quite come to the point where we're saying, they're ready to be assessed to see if we can get them off of ECMO. And it led to a lot of frustration. Our people were, it was just arguing and sort of this circular conversation that didn't move things forward. So we said, we need to establish a clear way that we go about doing this. And if the SAT and the SBT work so well, we decided to move forward with an SOT, a sweep-off trial, and sort of set this in clear parameters. And we wanted to make this as simple as possible. So let's do it as clean, as easy, as simple as possible, modeling on these other concepts. So let's find clear criteria someone can meet to undergo a sweep-off trial, an assessment of whether or not they're ready to come off of ECMO. And we establish those. And I want to really key on objective criteria. Whatever you're deciding, it shouldn't be because Surgeon Smith says they're ready to go. There's a reason Surgeon Smith says they're ready to go, and Surgeon Smith needs to put that down onto paper. Is it because their gas is this? Is it because their flow is this? What is it? There is an objective criteria we need to use, not the whim I have today based on what my drive-in from home was like. So clear objective criteria, clear mechanism through which you test this. And this works for VA, VV, ECMO. What is the way you're testing? If in VA, are you using an echo? Are you looking at their pulse pressure? Are you turning it down? How do you go about doing it? That doesn't matter. It's that you've got a clear mechanism through how you do it, and then clear criteria for failing. What do you do when they fail? And each day you do this just as we've learned with the SAT and the SBT. And what we saw that people came off ECMO much, much sooner. So they came off ECMO on average about 5 days sooner. They also left the ICU and the hospital sooner. I don't want to get too much into that, just based on the design of the study, et cetera. But the key point is that as we looked at these folks, after we implemented this, the day they met the criteria, they received an assessment, a sweep-off trial. Prior to that, where they would meet criteria, it would be 5 days before they would actually get a sweep-off trial, because no one was sort of monitoring that in a very close and manner so that we were doing this. So we were able to get people off much sooner, which was really cool. And I wanted to add a couple of things as we do this. So when we started this, it was slightly different than what it is. And I hope 5 years from now, it's slightly different from where it is now. 5 years, slightly different, because that means we will have learned something and we will be doing things better. And I would encourage you all to do that with your own programs. One thing we noticed was initially one of our criteria was improvement in chest x-ray. So we had improvement in chest x-ray, tidal volumes, oxygenation, as criteria. And they would meet all the physiologic parameters, but there's subjectivity in reading an x-ray. If two of you are standing back looking at it like this, trying to decide if it's better, that's not objective. 7.35 is objectively higher than 7.30 on a pH. Whether or not I think the chest x-ray is a little better and you're not sure is subjective. And so we saw patients whose x-ray had not gotten a bit better, maybe it even looked worse than when they went on ECMO, but their physiology was better. They came off ECMO, they did great. We scrapped the x-ray. We wanted to take away any subjectivity out of this that would lead people to not do this assessment. The next thing we did is we had it set up to where our ECMO specialist, who's a respiratory therapist in our unit, each morning would report off to us. They'd report off the blood flow, the sweep flow, they would report, any issues they had, et cetera, and they would tell us whether they met criteria for a sweep-off trial. And then it was up to the team to say, okay, let's do this. And what we would see is that they'd be like, great, let's do this. I'll come back after rounds. I want to see how they do. So they come back after rounds. We would do this sweep-off trial at 1 o'clock. 4 hours later, it's 5, 6 o'clock. Their gas looks great. They look great. We call the surgeon. Surgeon's still doing a transplant. And it's like, I don't want to decannulate this person at 9 o'clock at night when I finish this transplant. We'll do it tomorrow. They come back the next day. They got 6 transplants the next day. And this person who was ready at 7 a.m. is decannulated at 8 p.m. the next day. So that's not good. So we said, how do we how do we, and this is the part that gets controversial for the physicians, how do we take the physician out of this and make this all happen? Because as you see, the SAT works because a nurse turns off the sedation. An SBT works because a respiratory therapist does it. So how do we do the same and translate it to ECMO? So we said, let's have our ECMO specialists assess them at midnight and then put them on a sweep-off trial after midnight. And so that way, when you arrive in the morning at 7 a.m., the RT can report, put Mr. Jones on a sweep-off trial last night. He's been off for 6 hours. Here's his most recent gas. You can say, he looks great, that looks great. Call the surgeon at 7 a.m., and then they can work it into their day, and you've shaved another day off of their ECMO course by getting that going earlier and taking it out of the physician's hands. And so those were two things we've changed and we've learned as we've gone along that have helped us accomplish this. So finally, the key points, I would encourage you to set objective criteria to qualify for a trial off ECMO, whether that's VA, VV, VAV. Sit down as your group, look at what's published, think about what's important to you, and set those objective criteria. Eliminate anything that's not clearly objective. Define the method on how you're going to do it. Set clear pathway that someone will perform this study. Set objective criteria for failing and what to do when they fail. Then everyone knows exactly how this process is going to occur. And then once you've done all that, let the physician know the results at the end. And then you can make a decision about whether or not someone's truly ready to come off of ECMO. I think if you do that and tweak this as you go, that you'll have success in developing a weaning program. Thank you.
We'll have all the panelists take a seat up here, and we'll do a quick line of questions here for the panel before we go to break. And I'll let Dr. Zachary take over, and maybe his assistant.
All right, thank you very much, guys. That was a terrific talk. I certainly have some questions, but we'll open it up to the audience first. If you have some questions, just join us at the mics. Yep.
Yeah. Thank you very much for excellent talks for all of you, because as a doctor who spent a lot of time with and bed of patients, I really appreciate information which I got from you. And I started with ultrasound. There's really no excuses why people who put the cannulas don't take the ultrasound. It's important not only during the putting cannulation, but during, in fact, all the course of ECMO. Because when you, for example, put the patient awake, or, for example, and then because of let's say physiology, because during COVID pandemic, we saw how the diaphragm shift up, and when we stick cannula on the skin, so they move, even if nobody can do it, want to do it. So very important, and also do workshop in our hospital in Poland. Not so big because there's two program ECMO workshop. Mine is 3 times less, smaller than colleagues from Poznań. But what from what point we start is we buy ECMO, so we buy machine because we don't want to someone during the course ask a surgeon or a cardiologist to take it and for using. So the question is, because I would like to answer the question, what do you think about the their training. For what is your advice? I've heard that during 6 months they should be training because nurses and doctors. But when do you think they are, for how do you think about how many days or how many times they should learn? And you said, okay, you are good for the take care of patient on ECMO. What is your opinion? How many days time? Because it's important for us.
If I can just clarify the question, you're asking about the requirement for duration of training.
Yes.
Are you talking about for ECHO specifically?
For ECMO.
Okay.
Yeah. For ECHO, yes. For
ECHO. Okay, good. Yeah, perfect. Alrighty. Well, I can tell you certainly from an ELSO point of view, there is no standard, and it's not something we have any sort of definition on. Most likely, this will come from similar literature, either for cardiac or for intensivist training for ECHO. But I'd certainly love to hear your opinion.
Great question. There are critical care echo boards now. We don't require that. The training, we've actually even started training our cardiac surgical residents and fellows because the views that we need for ECMO
It's simple.
Yeah, they're simple. They're sort of POCUS. So there's really a lot of free reign from hospital to hospital. We try to have at least 50 exams before we sort of credential them. There's a big debate between credential and certification, and those things mean different things. But 50 is sort of the number that we've chosen. But again, it's something that we've trained even the cardiac surgical fellows and residents who have very little or no background in echo or ultrasound, at least to help during the guiding and the daily examination that we do in the ICU for VA ECMO.
That's great. Sounds reasonable, too.
Hi, Dr. Mason. It's me again. I'm back. So I'm totally on board. I think all these things are really cool in terms of extubating patients, keeping the sedation light, or even non-existent. But to be honest, one of the things I've kind of struggled with the past year is I'm a new attending, and I work with a lot of older, experienced ECMO nurses. And so I was wondering if...
Tough situation.
Yeah.
Start a support group for that.
I was wondering if any of you guys have any insights or advice about maybe like changing the culture and how you guys drove that.
Oh, that's a great question. This is Anya. It just brings up a lot of issues. Really, what you're speaking to, I think, is culture. Coming into an organization, maybe as a new person or maybe as not the most senior person, and trying to change culture. It is really hard. I think the most important thing to do is you have to live it with them. You have to be there, and you have to be patient. But when the patient is getting agitated and acting, demonstrating that behavior that would normally get them resedated, you have to be there, and you have to kind of talk the team down. One thing that helped me, it was a curse in some ways, but very helpful in others, my office was physically in the ICU. So I could hear the alarms going off all the time. Now, if you want to get some administrative work done, don't get an office in the ICU. But if you want to be present, presence matters. It really matters. And trust me, you'll chip away at it. You're going to have to be really patient. But once you'll see a shift in your staff at some point. Once they see it work a couple of times and they see a few patients battle through this delirium and then snap out of it, they'll become believers, and then the thing will take off and sustain itself. But early on, I think I say patience, presence matters, and just be there. Of course, if you can, a lot of centers will accept visitors. If there's a way to get one of your really experienced nurses to go see this somewhere else or win one of them over, maybe that's another strategy. But I feel for you, and we probably need an ELSA support group for that situation right there.
I would just follow up on that. I think choosing the right patient to do something different on that you think has a really high likelihood of success, celebrating that success, giving them a plan for when things go awry, as Phil said, and celebrating those successes. And what we found, we went through all of that as well, and we found their biggest concern was long-term negative effects that they're going to have. They were most worried, because nurses care, that's why they do what they do, and they're worried that this patient is going to either harm themselves acutely or have severe PTSD down the road. And for us, bringing the patients back at the end and them seeing that they did not remember any of that was actually really helpful for them. And continuing to sort of reinforce all the stuff that the PTSD, the anxiety, the depression is actually less when you do this, we found was helpful.
And I'll just add, I mean, this is obviously something new now with ECMO, but as you mentioned previously, when this whole discussion of, keeping patients more awake was just blasphemous. And it was difficult as a culture shift until the evidence came out. Unfortunately, in ECMO, the evidence is obviously lagging. We anticipate that it will be positive and it will probably show improved outcomes, at least anecdotally. It certainly seems that way. But hopefully with time that this will become just a new standard as well, and it'll be easier for places to accept.
Thank you very much for sharing valuable experiences. I have two questions. So TEE during ECMO cannulation, definitely it's helpful. And when we do ECMO cannulation in the operating room, we usually have a cardiac anesthesiologist and make the most of the info that we can have with TEE, and there's no question about it. But I think most of the ECMO cannulation occurs in the ICU, and if we could have a TEE at the ICU cannulation, that's a luxury, I would be ecstatic. And it usually doesn't happen in the ICU. At MGH, do you do that in the ICU cannulation?
Yes, so at MGH we do. We sort of service them 24/7. But I will say one of the things that we've been doing now is surface transthoracic, so we prep including the chest. So the chest is prepped in so that it's sterile, and we put the transthoracic probe in a sterile probe cover, and we have the cardiac surgeon resident or cardiac surgical resident or trainee actually helping also with getting those basic images, at least for guide wire identification, so that if it is 3 o'clock in the morning and the cardiac anesthesiologist is not available, at least you can have one of the other providers sterilely do a transthoracic sort of basic examination. So that's one sort of newer trick, let's call it, that we've done so that it stays sterile.
So that transthoracic cardiogram is done by cardiothoracic surgery fellow?
It can be done, yeah. So we've trained the intensivists, obviously, are well-versed in at least some of those POCUS examinations, and then even the cardiac surgical resident who comes to all of our cannulations, or most of the cannulations, are being trained to do that as well, some of those basic exams. And they actually come down to the operating room sometimes to do transesophageal echo basic examination. So I think ultrasound is becoming sort of ingrained in our medical education, at least here in Boston, and so I think that's really important.
Second question is about ambulation, and I have a special interest in ambulating ECMO patients. And people started walking with femoral cannula, and in my program, it's still a little special, and we've started doing it, and maybe 3 patients we've done. And one of the concerns that I have is that I've seen some cannula fracture in the past. And when we walk them, a growing cannula, when would it fracture, or can we do something to prevent fracture? Could you share your experience about cannula fracture or safety of the ambulation with femoral cannula, please?
Yeah, absolutely. So I have not seen cannula fracture in the femoral cannulas from ambulation. And I think maybe it's because the bend is gentle. I mean, if you look, even if you bend your legs to flex your hip to 90 degrees, it's still a nice gentle bend. I've seen cannula fracture twice. Both of them were bicable cannulas at the neck, where it's secured pretty tightly to the skin and there's a lot of weight pulling that cannula over with the tubing, et cetera. I've seen that twice. Once was actually very recently. The femoral cannula is nicely secured down the leg. I put one suture right where it goes into the skin. That's usually a purse string for hemostasis. I put one really tight suture on the plastic connector because I can tie as tight as I want on that. I'm not going to cut into the cannula. And then every couple of centimeters between that plastic connector and the skin entry side, I put another suture. And those I don't tie down super tight because you can cut into the cannula. If you tie really tight on a cannula over the wire wrapping, you can cut into it. But those are just to keep it from raising up away from the skin where something can get underneath it or kind of inchworming out. So that's how I secure it. Then the ECMO specialist, we typically use some of the adhesive devices. A lot of them are made for Foley catheter securement, actually. But we put like 2 of those on the leg that secure one at the thigh and one kind of at the knee and wrap around real tight. We have not had any issues with cannula dislodgement. And like I say, fracture, I think the bend is just gentle enough that it probably doesn't stress that cannula significantly. I have seen it twice in bicaval cannulas in the neck, though. We have not. We've had an accidental decannulation in my program last year. It was not ambulation related at all. We've never seen a cannula dislodgement. Rarely you'll see flow interruptions or something, but I would say that's unusual also. The patients that have been supine for a long time, we start them off on a flat tilt table and gradually stand them up. And then if they start to drop flows because they're, quote, orthostatic or their ECMO circuit is orthostatic, we'll wrap their legs in ACE bandages sometimes to help with that venous capacitance if they've been supine for a while, but generally hasn't been an issue. It's a big team. You know, we use a couple of extra hands. Everybody's pretty experienced. They always do a walkthrough before they get the patient up. But it's become quite routine for us, and we haven't seen complications of that.
Thank you very much.
Okay, I think we have time for one more question.
Thank you again for really fantastic talks. I'm Melissa Vogelsong. I'm an intensivist at Stanford. I will say, following up on the awake and ambulatory ECMO, that last question over here resonated very strongly. I am curious, you know, at least a subset of our VV patients will often come to us after having been deeply sedated and paralyzed. And I'm curious, what is sort of your average timeline for when you get them awake, when you're starting to walk? And do you ever, and maybe you are waking up and ambulating 100% of your patients. I'll be very impressed if you do. But do you factor in a patient's inability to reach that state when you're thinking about, well, how long do I keep supporting them on ECMO?
Yeah, so I call that being marinated in midazolam. We pick the patient up and they have been marinated in midazolam. When I get a patient like that, I get them all awake with somewhere between 2 hours and 2 weeks, kind of in that time frame. It's really difficult. I will tell you that my approach, number one, is don't wean the sedation, turn it off. If you ask the staff to cut the midazolam from, you know, it's 8 milligrams an hour, why don't we cut it down to 4 or 6? I guarantee you, if it's still hanging at the bedside, tomorrow morning, it's going to be 8. You'll never win this battle. So just discontinue it. Take it off of the MAR. Rarely you'll see a problem with withdrawal, with benzo withdrawal. But I just haven't seen that particularly often, but you may have to deal with that. Likewise for opioids. Just stop them. Turn them off. I've seen withdrawal issues from opioids more often, I think. Methadone is magic for that. You know, low dose of methadone takes the edge off. So don't wean it, just stop it. Now you have to give the staff something to fall back on when the patient does get agitated. Precedex or dexmedetomidine, to make sure we use generic names, is fantastic when it works. But I think you all agree that dexmedetomidine is great for some patients. Other patients, you can't even tell they're on it. It might as well be water. So we use a lot of atypical antipsychotics. They don't prevent delirium, but they manage behavior. And that's very helpful. If you need deep sedation or you need something more, we use propofol relatively infrequently, but propofol is available. Sometimes you truly do need deep sedation, not often, but even the patient that just is overly agitated, you can often get a patient sedated a little bit with propofol where they're still interactive, et cetera. So that's kind of how I approach that problem, is do not try to wean the drugs, just stop them. As far as what percent we're ambulating, we're definitely not ambulating 100%. I think we get 95% awake, though. I think it's pretty unusual we have a patient that we can't get awake and relatively clear-headed. Ambulation, I can't tell you, maybe it's 50%. Some cases we don't try that hard. A VA ECMO case can be on ECMO for 4, 5, 6 days. It's not worth the effort. Get the patient awake, do some PT in bed, that kind of stuff. But it's a challenge, though. The patient, I tell the families too, listen, they're all going to wake up crazy. They all wake up crazy. If the family can be in the room when they wake up crazy, that's really helpful. COVID was a disaster for that. Obviously, we didn't have that resource we do now. So having the family in the room to help and that kind of stuff, and just preparing the whole team. Look, I know what's going to happen here. The patient's going to wake up crazy. This is how we're going to work through it. That does not include restarting deep sedation. And again, as I was saying, the prior gentleman, once the staff sees a couple of patients work through that process, it clicks for them. They're like, oh, delirium, we're the problem. We caused this. Sedation is the problem. It cannot be the solution. Once they see that play out a few times, it gets a little bit easier. So, good luck.
All right. Well, thank you again to all of our speakers. We were a little over, but I'm still going to give you a 10-minute break to get up, stretch your legs, get back in. We'll start up at 10:45.